ones that are coming as well. So welcome to everybody. Thanks to everybody joining us on Zoom as well. Hope we have a good one today. Hope so. Let's say hi, Doc. Come sit. All right. So we're going to start with our ECG analysis for today, just to go through and see what we can learn. I hope today's is a nice one. I can't remember what it was. Oh, yeah, it's a fun one. Okay, that's good. All right. So this is the ECG that we're going to analyze. We'll go to the proper ECG in a second. All right. But let's just remember what we've got to analyze. We've got to analyze axis, analyze rhythm. When we analyze rhythm, we analyze the P waves, PR interval, QRSs, QRS after every P, regular groupings, analyze rate, analyze each zone. And for those of you who are joining us maybe now in a little while, on the Google, what you call it, folder, you'll find all the old lectures. So you can even go back right to the basics. Right? You're not part of our group. I'm saying you haven't joined our group before. All right, at the end of it, I'll give you a link to a Telegram, and then it's got a link to all of the old ones that we did. So we start right from ECG basics. In other words, how you do all of these things. And then we build up to the point where you can look at this, like how these guys are looking at it. And I was like, yeah, it's not so bad. We can, in fact, that's why I say today is like relatively an easy one. But for some people joining us, I was like, what is this? Yeah. All right. So let's just hide this for a little while. Okay. So here we go. Let's start first with the patient that we have, right? So we have a 50-year-old woman with chest pain and diaphoresis. You guys know what diaphoresis is? Yeah, extreme sweating, right? So a diaphoretic person is covered in sweat, right? Absolutely covered. And it doesn't matter what the temperature is, they're absolutely soaked, right? And she's diaphoretic for the last 5 hours. So now you were sleeping in your car, you are the medical officer on call, your intern phones you or your student phones you and says, this is the history. So in the 2 minutes that you walk from your car, you stretch, all of that, what are you thinking about immediately? What's the first thing that comes into your mind when you hear 50-year-old chest pain, 50-year-old woman, chest pain, and she's sweating like crazy for the last 5 hours? What should be the first thing that comes into your head? Yes, myocardial infarction should be the first thing that comes into your head. All right. And then you start going down the list of what else it could be. All right. So what are the other possibilities, for example? Let's say you could have pulmonary embolus. Very good. It could be a pulmonary embolus. There's no doubt. Okay. That's also, it causes the exact same symptoms, although not necessarily diaphoretic, but it can. What else can cause chest pain? That's basically what we're asking today. You know? And then we'll get into what we analyze from it. Because remember, ECG is to help your diagnosis. You can't make final diagnosis. You can get, okay, I really think it's this, and then I want to investigate that. Right. Okay. So we already said MI. We already said pulmonary embolus. Anything else that we may consider? There must be other things, because those can't be the only causes of chest pain. All right. So pericarditis, infective conditions. All right. What about just a simple lower respiratory tract infection? Can also lead to that. What about a pneumothorax? Then we go into what you call it esophageal tears. You go into the more detailed ones, yeah, you know, and things like that. But initially, when this patient comes in for the first time, the first thing that you'll think of is this a myocardial infarct? So in other words, when they phone you, you're not going to first go to the toilet, have a smoke, then go and see the patient. You say, no, let me at least go and see what's happening first, and then decide what to do. All right. So in other words, the first thing that you do is you go to this patient and say, okay, listen, I suspect it could be an infarct, guys. Let's put an ECG on. ECG takes us 5 minutes. We're going to analyze the ECG, and then we're going to decide what's going on. Okay, right. So now we have done that. We've put our ECG on. We suspect a myocardial infarct, pulmonary embolus, Now our ECG is going to help to guide us. All right. So let's have a look at our ECG then. So the first thing we're going to try and work on is the axis. All right. So you guys have worked out the axis with me before. Let's work it out. Oh, sorry. Wait. Go back. Right. Okay. Right. It's doing it again. Sorry. Okay, I just wanted this. Sorry, I wanted to annotate. My apologies. Nobody saw that. Okay, so let's draw. Right. So let's put our little grid over here. Okay. So we remember, right? So we've got lead 1 here, all right, and we've got lead AVF here, all right. So let's just do it like that. Okay. So let's look at. Sorry, let's just get those people in. What's happening here? Okay, they should be joining now. All right, that's fine. All right, so remember we've got lead 1 over there and we've got lead AVF at the bottom. All right, so let's look at lead 1. All right, it's pointing in which direction? Pointing up. All right, so it means electricity is flowing towards lead 1. So it's either there in the left side or it's in the normal side. Okay, so those are the two possibilities. So we already know we don't have an extreme right axis and we already know we don't have a right axis. Okay, all right. So which one is going to tell us what we have now? We're going to look at lead AVF. All right, and which way is lead AVF pointing? Downwards, which means electricity is moving away from it. All right, so if this is lead AVF and if electricity was moving towards it, it would mean that it would be there. But we know that electricity is moving away from it. So the only one that's left is a left axis deviation. All right, so we know, all right, we've got a left axis deviation. Okay, so now we've got to think to ourselves, what are the causes of a left axis deviation? I mean, not the exact causes. What I'm saying is just in general principle, it means either damage has taken place to the right heart, so the electricity is getting shunted to the left, or the left heart is enlarged for whatever reason, and the left heart is now taking a lot more electricity. All right, that's a simple way of putting it. There are some other things, but let's just keep it at that for now. All right, okay, so the next thing we're going to look at is let's look at the rhythm. All right, so let's look at our P waves. Can you guys see P waves over there? We've got a rhythm strip, a nice rhythm strip actually. So let's look at our P waves. How do they just look? Relatively normal, isn't it? So there's not much going on there with the P waves. Let's go through the whole thing and make sure P waves look all right. Let's look at our PR interval. All right, so in other words, the time from our atrium to our ventricle. All right, so we've got 1, 2, 3, 3.5 to 4 around there. So it's still within the normal. Okay, so we've got a good PR interval. All right, let's look at our QRS complexes themselves. Are they narrow or are they wide? Quite narrow, isn't it? So that means the ventricle is listening to the atrium. Okay, and then do they follow every P? They do. You know, so that means every time the atrium contracts, our ventricle is contracting. So we're not really looking at a rhythm disturbance in this case, all right? And then are the groupings regular? They are, right? So it's not a rhythm disturbance as such. Okay, let's look at our rate. Okay, so if we work out our rate, we've got 1, 2, 3, so it's about 100. So we've got a tachycardia with the sinus rhythm. So we have a sinus tachycardia. All right, good, right, no problem. Right, now let's look at each zone. All right, so where would you guys like to concentrate? Where would you guys like to start? Can you start with the abnormalities or just follow our old system? What would you like to do? Let's run for the abnormalities. Okay, so the first two that we look at, V1 and V2, these are our septum. All right, so what do we notice on our septum? What do we see? Suppose we can talk about that. What is this? ST, that's the ST segment, all right? Is it above or below? So we've got an ST elevation, very good. And what did we say we call these waves? These negative deflections that are quite wide and deep, although maybe you couldn't argue with it here, but let's just say for interest's sake, all right? What would you call them? Q waves, isn't it? So even though this is not technically a Q wave, you can see it's got this little thing here. So this is actually a bundle branch block here, right? An incomplete. But anyway, that we're not going to be too worried about right now. Let's concentrate more on the infarct side of it. So we know in V1 and V2 we've got ST elevation. So that tells us something's happening in the septum. All right. And let's go to V3 and V4. So V3 and V4 are looking at the anterior part of the heart. Okay. So what do we see in V3 and V4? What's happening there? ST. Very good. ST elevation. And what do we see here? Again, we were talking about it in V1 and V2. It's very deep, wide, initial deflection. Very good. Q waves. All right. So what's the thing? What do you guys remember about Q waves? What did I teach you? Q waves tells you that there has been ischemia. It just doesn't tell you when. Could have happened 10 minutes ago, could have happened 10 years ago, but it tells us that there was ischemia, all right? So especially when it's involving the entire thickness of the myocardium, all right? That's when you get Q waves, all right? So always be careful of Q waves. They always tell you, listen, something has happened, but I just don't know when. Now, if you have a patient, for example, coming with chest pain for 5 hours, what would you assume? Is that it happened Well, now, that's what I mean. You know, it's not an old thing. You'd assumed it's happened now. And what you would assume, remember what we said, it happens when the entire myocardium is involved. So it means it's happened quite rapidly. It means over 5 hours, that entire thickness of that myocardium has died off. Now, it could be an older one, which you would get from history. And what would you do? You would ask the patient, is this your first episode? They say, no, I've had this before. Then you could say, okay. But if they tell you it's your first episode, it means you've got to get worried. Because if this happened only now, and it's already involving the entire myocardium, something's gone wrong. Bad. There's a bad blockage if it is an ischemia. Right? Then we're going to look at the lateral side of the heart. So which four make up the lateral side? V5, V6, and which other ones? Come on. These are the lateral leads, which are the high lateral leads. 1 and AVL. Okay, don't forget that. All right. So remember, these four must look similar. Okay, but let's look at V5 and V6. Do we notice anything? Do we see anything? Anything here in V5? You could argue it's just, but this is not an ST elevation per se. All right. So in ST elevation, you can see the entire thing actually takes off from above the baseline. All right. Whereas this one here takes off from the baseline. So it's not actually an ST elevation. It's what, even though it's not that steep, we would say it's sort of like a takeoff, you know, a high takeoff. But there's no evidence of ischemia there. And what do we see in V6? Well, there's two things actually to notice. What do you notice here? What's this wave called? P wave, isn't it? What do we see? What's happening to our P waves? Do they look normal? No, it's almost like a biphasic something. So something is happening in that area with the atrium from that point of view. Okay, but that can just be a rotation of the heart. Right? But what's happening in V6? What do we notice? So we have a PQRS. What's the next letter that's supposed to come? In other words, what's this wave? PQRS. That's a T wave. What do you notice about your T waves here? Flattened, very good. Okay, so that means something's going on. Okay, so flattened T waves, inverted T waves are non-specific, but it can point towards an ischemia. Now, of course, we've got other signs of ischemia here, but it does point towards it. Okay, and what do we see in lead 1 and AVL? No real ST elevations, but what do we notice again about the T waves? These ones are slightly flat, and these ones are a bit inverted. Okay, so even though it's not involving the lateral side of the heart, but it's showing signs on the lateral side of the heart. Okay, all right. Then what's the next zone that your guys want to look at? So we looked at the septum, the anterior, the lateral. Which section haven't we looked at? The inferior part of the heart. All right. So let's look at leads 2, 3, and AVF. Okay. So what do we see on leads 2, 3, and AVF? Anything abnormal? What about the STs? How are you? So what do we notice about the STs? Is there anything? Sorry? Not at all. If you look here, right? So basically, the best place to look when you want to determine ST elevation or depression, you can look between the P and the R, for example. You see there's no activity. All right, so when there's no activity, that's called our isoelectric line, our zero line. All right, so in other words, when the heart is at rest, it comes to zero. And then ST elevation or depression depends on its relation to that. So in this one, for example, if we had to, let's do it. Let's draw a line. Oh, sorry, somebody's been chatting. I didn't see. Thank you. Was that inversion? Sorry about that. I didn't see that. Just annotate this a little bit. Sorry. All right. So let's draw this. Okay. So let's start a line from there. So you can do this with your pen. You can do it wherever you want. Let's go across there. Right. So that's our ST, our baseline. Right. Now look at your ST segments. Do they deviate from the ST line? Not really. It's kind of there, isn't it? It just sits over there. Let's look at the next one. All right, so there's our baseline. All right, so that's in other words when the heart is at rest. And what do we notice there? Kind of sits there, isn't it? It's not really going anywhere, yeah. And we look at the same thing there. All right, as compared to this one. Let's put this one. Does that make a bit more sense now? Can you see the difference? Okay, so that's an ST elevation. That is a nothing. Okay, as compared to it, let's say from here, we were to get something that looked like that. That would be an ST depression. for example. So in other words, imagine we've erased that line. We've got something that's an ST depression. Okay, all right, let's clear that. And then the last thing we need to look at is the right side of the heart, or AVR. Do we notice anything over there? Yeah, not really. Okay, it's kind of within normal. But where's the problem now? What did we say when we want to diagnose a myocardial infarction? You guys should remember this. If you've got ST elevation somewhere, there should be something else that you should see. You should see something called, I'll give somebody on the chat a chance as well to answer this. If we have ST elevations on one side of the heart, what should we see on the opposite side of the heart? Let's see. Yes, reciprocal changes was there. Very good. All right. So we should see reciprocal changes. What is a reciprocal change? A reciprocal change means exactly that. If something is happening on one side of the heart, the opposite side of the heart should be seeing the exact opposite. So for example, if you have, like, look at this bottle and I push it towards you, you see it falling towards you. What should I see? Falling away from me. So what are we not seeing on this one? ST depressions. So what does that mean? That we don't have an infarct? It's making it less likely. Agreed. Doesn't mean we don't have it, because we've got other signs of it. All right. So what could our differentials be now? That's the question. What causes just ST elevations? So I'm looking at all the eager faces who want to answer. But nevertheless, I'll tell you. Okay. Stop, put your hands down. Stop answering altogether. It's fine. So there's a few diseases that cause it. Right? Most common is pericarditis. All right, pericarditis can cause it. Okay. And the second can be something called a ventricular aneurysm. All right. So what is a ventricular aneurysm? The ventricular aneurysm means exactly that. The ventricle is no longer alive and it's bulging. All right. So it's bulging out. It's formed an aneurysm type of structure. And so if you think of a aortic aneurysm, a cerebral aneurysm, the wall of the vessel is basically bulging outwards. So this is the exact thing that happens with the ventricular aneurysm. But it happens after the wall has died. So in other words, the wall has died off completely. You now have this bulge. So every time that the heart is beating, this thing is just bulging out like that. What do you think? Dangerous, not dangerous? Yeah, extremely dangerous, because if that thing pops, yeah, patient, everything just flies out, right? The typical definition of exsanguination, all right? So in other words, they can completely exsanguinate within a very short period of time. So are you still going to the toilet now? No, because it could still be an infarct, but now you have to exclude something else as well. Is this a ventricular aneurysm? How will you exclude a ventricular aneurysm? What can you use that's sitting in your emergency department that could help you to look at the heart? Very good. Yeah, you could do an ultrasound now to see it. Okay. So a quick, even somebody who's not very good at ultrasound could immediately see it. Listen, there's something going wrong with this heart, because there's one part of it that's just like popping out like a balloon, or is in an odd shape or something like that. And then immediately you'll say, listen, there's something going on. And it could actually help you, to say that, listen, am I really going to send this patient now to cardiothoracics, or am I sending this patient to the physicians? Okay, so those are the things that you can use. However, it may not be a ventricular aneurysm. Let's say you do put it on, there's nothing to suggest an aneurysm, there's no bulge, nothing like that. Then you would come back to, okay, it could be pericarditis, which is an infective condition, or it could be, myocardial infarction. Now, some of we know it's cardiac. So in other words, we've excluded things like pneumothorax, we've excluded things like an LRTI, we've excluded all of those things for now. All right. And what we have said as well, the other thing was a pulmonary embolism. All right. And the one thing we note on this is we don't really have signs of a pulmonary embolism, all right, which we learned before. Okay, there's not much to suggest it here. So we're still looking at a myocardial infarction, which means that we would treat this patient as a myocardial infarction. And we know it's a anterior septal, so we'd give them TNT, we'd give them morphine, we'd take the enzymes, we do things like that, but now we're more confident in what we are doing, as compared to just came in with chest pain, boom, TNT, morphine, send the patient off, send the enzymes off, go to the toilet, because we didn't do anything else, all right? So that's what I'm saying. In a few minutes, we can immediately know what's going on, all right? So your ECG takes 5 minutes, your analysis can take another 5 minutes. Within 10 minutes, you are more confident. You can even start telling the physician on call, let's say, listen, I've got this patient, it could be pericarditis, could be a myocardial infarct. So I've taken my enzymes, I've treated the patient as an infarct in the meantime, considering the age, the history that's happening. But at the same time, I've taken infective markers. I've done all of that to see if it could be a pericarditis as well. Because if my enzymes come back as completely normal, it doesn't mean nothing's happened. The patient still needs enzymes later on. But what if my CRP is through the roof? My white cell count is through the roof, then I know this is a pericarditis. So this is how you have to think about it, all right? So let's have a look, all right, at what the answer was, although everybody saw it already, but let's have a look, all right? So we have a sinus tachycardia. The rate was worked out to be 105, and then eventually it did become an acute anterior myocardial infarction, all right? So we said anteroseptal, so we weren't far off, with left ventricular hypertrophy. So the question is, how do they decide left ventricular hypertrophy? So the one thing I can tell you guys, if you want to work on left ventricular hypertrophy, is it left ventricular hypertrophy? Look at 1 and AVR, which look at the majority of the left ventricle, and compare it to lead 3, which is the complete opposite of it. So if the left ventricle is enlarged, you'll notice very tall QRS complexes on 1 and AVR as compared to a complete dip in lead 3, right? Because they're on the complete opposite side. So in other words, 1 and AVR are looking at this huge ventricle that's pounding in front of it. So it's seeing a lot of electricity coming towards it. And lead 3 is on the complete opposite side, seeing all this electricity moving away from it. Is it a diagnostic criteria? No. Diagnostic criteria for a left ventricular hypertrophy are a bit different. You have to consider all of the, what am I trying to say? All the QRS complexes, you have to measure exact blocks and things like that. But if you want a quick analysis, we're not cardiologists. We just want a quick analysis. That's the quickest way to work it out. Look at 1 in AVR and look at your dip in 3. So you could have, for example, big QRSs here, but you don't have something so big over there. Then it would make you go back and look at your criteria, right? But just a quick one, just so that you can eyeball it as well, right? So Q waves have already developed in the anterior leads, indicating the presence of infarcted tissue, which we mentioned, right? So that means this patient is progressing quite quickly. So whichever artery is blocked is quite heavily blocked, okay? Because it's not allowing any blood to go through, basically. So the tissue is dying off completely, all right? But the persistent ST segment elevation indicates ongoing ischemia of myocardial tissue not yet infarcted, okay? So what it tells us is that as much as we've talked about ST elevations and your differentials, you must remember myocardial infarction always remains at the top of your list, even though you are not seeing reciprocal changes in this case. Okay, why are you not seeing reciprocal changes? Difficult to say. There's quite a few reasons for it, okay? But in this case, we're not going to get into the nitty-gritty of that. But let's put it could come down to lead placement, all right? That's one of the more common issues that we see. It's not placed correctly. It's placed in the incorrect parts, placed over bones, things like that, especially your limb leads. A lot of people place it over the lateral and medial malleolus, which is bone, and then you're not going to pick up much because it doesn't conduct too well. The other thing is that once you have Q waves that have formed, so in other words, if you do ECGs for people who have had myocardial infarcts, and then you like ECG them after a year or two, they still have their Q waves, but they don't have reciprocal changes. So the way that the tissue infarcts also impacts how the other side looks at it as well. Now, and then of course you just get the odd ones, right? Where there's just no reciprocal changes for whatever reason, all right? In this case, it can also be down to the left ventricular hypertrophy, simply because of the size of the left ventricle. The area that may be infarcted may not be large enough to show on the other side. So these are just some of the reasons. The reason why I went into the differentials because you need to know them, all right? Let's see, some wisdom from the chat. Yes, can be no reciprocal changes because it's septal as well. Very good. Thanks, Uzair. So that's another reason for it, okay? So, you know, Uzair used to present a lot in internal medicine, so he knows his stuff. Plus, he just got married. So he's got enough time now. He doesn't go to movies, doesn't do anything. Just has to be with his wife so he can read. But he's 100% right, okay? Just joking. All right. So, you have to consider all these differentials. Okay, I'm sorry, Uzair, you don't have to swear me on the chat. Okay, I don't know what that symbolizes, but I don't think it's a nice thing. Okay. Okay. All right. So from the history to the ECG, it was more suggestive of infarction. So this is the type of patient that you will treat according to our protocol. This is the type of patient that you will phone the physician about and say, listen, it really looks like an infarct. Then the onus is on the physician. Are they coming? Like in our setting, are they coming? Are they waiting for enzymes? Because if they say they want to wait for enzymes, should something go wrong, they are now liable. We'll look after the patient until that time. But if the prognosis is poor, the patient ends up getting worse, the patient then sues, the onus is on the physician, because the physician is supposed to come out immediately. But you can at least express to the physician that, listen, these are the things that we are finding. You should come and see this patient. This patient deserves more than what we can offer them. This patient requires reperfusion. How is this patient going to be reperfused? Either thrombolysis or percutaneous coronary insufflation, stenting, all right, stenting or balloon therapy, angioplasty. So in other words, that's what you're going to tell the physician. Then it's up to them. Their bed is warm, they don't want to come, it's on their head. We keep the patient going until that time. Okay. Is this patient having a good or a poor prognosis? Unfortunately, it's not a very good prognosis. The simple reason being, she's infarcted very quickly. She's continuing to infarct. And until we actually reperfuse that tissue, she will continue to get worse and worse and worse. And the more tissue you infarct, the less functional tissue, the less our heart can physically work. All right. If I cut off just your fingers, majority of your hand will still function. Cut off your wrist, less. Cut your hip midway, elbow. So as you lose more and more tissue, the functionality gets less and less and less. Once I take off your shoulder, you've got no arm on that side. Agreed. So it's the same thing with the heart. As you lose more tissue, the ability for it to contract decreases. So your patient's ejection volume, ejection fraction goes down and down and down until eventually it's zero and your patient dies. Okay. So today's was a nice one. It wasn't too complicated. In other words, it was a relatively straightforward one, but just to get everybody thinking about how you should analyze an ECG. All right. So I don't think there's any more. Yeah, I don't have any jokes this week, sorry. Okay, maybe on the next one. All right. So I hope you guys enjoy. I don't know if there's any questions or anything that you're, I mean, anything. It doesn't necessarily have to be, you know, I don't know, anything about the ECG itself or about myocardial infarcts or anything like that. Let me just leave this on. Was there any questions? Nothing too difficult, please. I'm still waking up from my coffee. Okay. All right. No, that's fine. Listen, so these are the types of things that we see relatively often in an emergency department. It's not uncommon to see infarcts. Oh, no. Let me see. Oh, okay. Thank God. All right. No problem. All right. No. But listen, if you guys come up with questions later or if you think of anything, more than welcome, message me and I'll try and answer. And message on the group, then everybody can see what the question is and then we'll go through it. All right. So on Wednesday, we will start with radiology X-ray. And until then, we'll stop the meeting for now. I'll post the video a bit later. Okay. All right. Thanks.